സ്റ്റാർട്ട് ചെയ്യാം. സ്റ്റാർട്ട് ചെയ്യണം.
Yes, sir. Can I? Yes, sir.
Start.
Good morning, teachers and my friends. Today's topic is role of staging laparoscopy in gastric cancer. These are the debated questions in staging laparoscopy for gastric cancer. I'm directly going into the debated questions. First one is, what is an adequate indication for staging laparoscopy? What are the indications for staging laparoscopy in case of gastric cancer? Then the second question is, how to do a staging laparoscopy? What are the various steps in doing staging laparoscopy? And does a staging laparoscopy provide accurate information regarding the peritoneal dissemination? Is the information provided by the staging laparoscopy adequate or not? That is the third question. And the fourth question is, the yield of staging laparoscopy, is the yield of staging laparoscopy different in different locations of the tumor? That is, if it is the gastric cancer or if it's a gastroesophageal junction cancer, is there any difference in yield? The fourth question is, staging laparoscopy, is it safe? Is it a safe procedure or not? Are there any risk involved in doing a staging laparoscopy? Is there any oncological threat in any threat in oncological safety of staging laparoscopy? And the sixth question is, a second look laparoscopy, that is after the neoadjuvant chemotherapy, is needed or not before doing an radical surgery. Then the last question is, staging laparoscopy, does it provide adequate any oncological benefit is there by doing a staging laparoscopy? Going directly to the first question, that is, which are the indications for staging laparoscopy? These are the two main trials which included staging laparoscopy in their trials. First one is JCOG 0501 and JCOG 0405. Both are trials which looked into the efficacy of neoadjuvant chemotherapy. And first study included the patients which are large type 3 cancers more than 8 centimeters and also type 4 cancers. And the second study also included patients with bulky lymph nodes and para-aortic nodes. In their study, they included the staging laparoscopy was a component of their study, and these were the indications they used for doing staging laparoscopy. These are the patients they selected for staging laparoscopy and the further studies. And other studies which looked into the efficacy of staging laparoscopy included these following patients. And first one is poorly differentiated cancers and cancers with Linnaeus plastica-like features and equivocal CT findings are all indications for doing staging laparoscopy. And mainly Borman type 3 and type 4 tumors are all indication for staging laparoscopy because of higher chance of peritoneal dissemination. And type 4B, T4B and T3 and T4B cancers are also indication for staging laparoscopy. These are some other studies also showing some of the indications of staging laparoscopy they used for their study. And to conclude, these are the main indications for doing staging laparoscopy in a patient with gastric cancer. Mainly, if it is a type 3 or type 4 cancer, type 4 of staging cancer, gastric cancer, where the peritoneal dissemination, chance of peritoneal dissemination is high, and equivocal CT findings for peritoneal dissemination, or if there is any equivocal CT findings showing borderline operability with infiltration, we can go for a staging laparoscopy. Or if it is a poorly differentiated adenocarcinoma where peritoneal dissemination is seen commonly. And these all are the uh, indications. Also, if there are multiple nodes in the peritoneum, perigastric and para-aortic region, we can consider doing staging laparoscopy before going for a planning and radical curative intent treatment. These are the various societies which recommends patients for staging laparoscopy, recommendations by various societies. Uh, Main one is the Society of American Gastroenterologists and Endoscopic Surgeons. They recommend T3 or T4 gastric cancers they recommend without evidence of lymph node or distant metastasis on high quality pre-op imaging can be considered for uh, staging laparoscopy. And these are the other recommendations by various other societies. So that is the first question, and we dealt with the indications for staging laparoscopy. Now coming to second question, that is how to do a staging laparoscopy. And we know that staging laparoscopy, uh, we also do staging laparoscopy, and the first thing is to put the patient in the Trendelenburg position, and we will put an umbilical port with a 30-degree laparoscope and see whether any ascites is there or not. That is the first step. And if ascites is present, it should be sent for cytological analysis. And uh, second thing, if there is no ascites, it is recommended that 200 cc of normal saline is to be instilled into the peritoneal cavity and aspirated from bilateral subdiaphragmatic spaces and also from the pelvis. That is the recommendation if there is no ascites. And after that, the third step is to look for any obvious peritoneal deposits are there or not over the liver, and also any presence of any obvious enlarged lymph nodes are there or not. If there is any peritoneal deposits or any liver nodules are present, it should be sent for an HPR. And it is said that it is recommended that to avoid maximum using cautery for taking these biopsies to avoid um, false reports. And the next step after that is the perigastric nodes should be uh, along the greater curvature and lesser curvature should be inspected and biopsied. And next is to inspect the portahepatic and gastrohepatic ligaments should be inspected carefully. And next is to inspect the pelvic cavity hepatic surface, the gastrohepatic omentum and gastrocolic omentum, right and left peritocolic gutters, the transverse mesocolon surface and root of mesentery should be done. And then the after inspecting the entire visible peritoneal surface, we can we can consider inserting a second port for mobilizing the liver. That is, the left lobe of liver can be elevated and look for any metastatic lesions in the gastrohepatic ligaments and proximal third of the stomach. And um, next is to entering into the uh, lesser omentum. That is another uh, topic of debate whether entering the lesser omentum is important or not. Um, Several studies has had considered this, and many of the studies concluded that there is no incremental detection of peritoneal dissemination by doing the omental bursa examination, but it is recommended by the American Society of Gastroenterologists and Endoscopic Surgeons should be routinely done. And further step is to use the help of an endoscopic ultrasound for detecting any deeper liver lesions or any other lymph nodes are present or not. That can be considered. and also to detect the depth of lesion. Depth of the primary tumor can also be assessed by an endoscopic ultrasound, that is known as an extended DLAP. And that is the various steps in doing staging laparoscopy. So we have addressed the first two questions, that is the indications and how to do staging laparoscopy in case of a gastric cancer. And coming to the third question, that is, will we get an accurate information about peritoneal dissemination in case of gastric cancer by doing staging laparoscopy? These are the numbers reported in various studies. There is a huge discrepancy in numbers between Japanese studies and Western studies. In Japanese studies, uh, the detection rates are from 42.7% to 53.4%. Detection of peritoneal metastasis is there, and other in Western countries it may range from 7.8 to 40%. This discrepancy is due to the eligibility criteria used in JCOG trials, because they have selected patients with more advanced cancers where higher chance of peritoneal dissemination is there. That is type 3 and type 4, and patients with multiple enlarged perigastric and paratic nodes. And false negativity of staging laparoscopy can range from 0 to 17%. And next is to compare the sensitivity of staging laparoscopy with CT scan and ultrasound. First is there are studies that compared the sensitivity for detecting hepatic metastasis and also for detecting peritoneal metastasis. And for detecting hepatic metastasis, staging laparoscopy have a sensitivity of 96%, where CT scan is 52% and ultrasound 37. And in case of peritoneal metastasis, ultrasound is 23%, CT is 8%, where staging laparoscopy is having a sensitivity of 69%. This is the thing. And uh, it is recommended by the American Society of Gastroenterologists by that the routine use of subphrenic cytology and pelvic lavage gives a better yield of cytology when we do as a lavage cytology. And direct invasion of the gastric cancer to the pancreas, if suspected in CT scan, exploration inside the omental bursa is also recommended routinely. These are the various studies showing the false negativity rates, which can range from 0 to 17%. That is the range of false negativity rates of staging laparoscopy in case of gastric cancer. And after that, the third question is there any difference in yield of staging laparoscopy when the primary tumor site is concerned? There are not many studies looked into it. Only few studies are there. And except one study that we can see or hear, the gastric cancer is having a higher yield than esophageal junction cancers. And only one study from USA is showing a higher yield in esophageal junction cancers. So that is the comparison between these two. Coming to the next question, is this a safe procedure? That is, what is the complication rate, and which all are the complications that can happen in case of staging laparoscopy? The reported rate of complications is 0.4%, and the most commonly reported complication is intestinal injury. Others are bleeding, infection, and other visceral injuries. There are no mortalities reported till now. And the other question that raised is the port site metastasis, but the recent evidence shows that the port site metastasis is not due to the carbon dioxide chimney effect. It is mainly due to only the biological behavior, the aggressive behavior of the tumor is the it indicates the biological behavior of the tumor, and there is nothing to do with um, the laparoscopy. Coming to the next question, the repeats or a second look staging laparoscopy is needed or not after an chemotherapy before doing surgery. Um, the question is peritoneal. There are two reports we get after doing a staging laparoscopy, that is um, mentioned as P1 or CY1. P1 is the peritoneal deposits. P0 is if no peritoneal deposits, it is mentioned as P0. And if there is a peritoneal metastasis, that is P1. If cytology is positive, that is CY1, and cytology is negative, CY0. If peritoneal deposits are there, then there is no question. Patient, it is considered directly as a metastatic lesion and will go for a palliative treatment. And if peritoneal deposits is negative and only cytology is positive, which is also very rare, and that is the scenario where the questions raise. And there are also no clear evidences for that what to do with such kind of patients. And only if the cytology is positive, some of the studies are saying that we can consider going for a neoadjuvant chemotherapy. And if the repeat cytology is indicated in such kind of case, and if repeat cytology comes as negative, there are chances of going for a cure after curative treatment, that is radical surgery. And if the response of chemotherapy was poor, then the disseminated nodules may be growing. Uh, there is a 12% positivity rate after a second staging laparoscopy. Around 10 to 12% conversion into a positive staging laparoscopy can be seen after a negative staging laparoscopy before neoadjuvant chemotherapy. So conversion surgery, that is a second look conversion surgery, can be considered if a second look staging laparoscopy confirmed that this CY1 is converting to CY0 after induction chemotherapy. Uh, P1 converting to P0 is cannot be, according to the recent recommendations, P1 will usually go for a palliative intent treatment. These are the various studies reporting the conversion rates. That is 56% conversion rate is reported by Mercer et al. And Lawrence and et al. Reported a 37% conversion rate after a neoadjuvant chemotherapy. So improved only overall survival is not there. Only um, case-specific survival rate can be improved by converting it into a negative cytology. Coming to the next question, what is the oncological benefit in doing a staging laparoscopy? The main benefit is for avoiding a non-therapeutic laparotomy that we know, and by detecting an occult peritoneal disease, we can avoid a non-therapeutic laparotomy, and can reduce the other benefit is to reduce the interval between an induction chemotherapy and surgery can be reduced, and unresectable disease. If the disease is unresectable, then the survival is the same even if it is unresectable disease. So these are the oncological benefits, main oncological benefits, and this is the thing I have already mentioned. Good prognosis is observed if the CY1 can be converted into CY0 after neoadjuvant chemotherapy. And another study which looked into it is the JCOG0501, where eligibility criteria are large type 3 and type 4 cancers with cytology positive and localized P1 diseases. And they observed that there is no benefit for neoadjuvant chemotherapy or immediate surgery followed by postoperative chemotherapy. Another trial is a regatta trial, which looked into the benefit of palliative gastrectomy for patients with peritoneal dissemination, and it concluded that there is no benefit in doing a palliative gastrectomy for patients with no added survival advantage is there. And so cytology positive patients should be considered as M1 diseases, but there is no uh, uh, evidences for clear-cut evidences where whether we can go for a whether these patients should be considered for palliative treatment or a curative treatment, and conversion following neoadjuvant chemotherapy uh, can be can result in a disease specific improvement in a disease specific survival. Coming to the next question, and which all are the patients where the staging laparoscopy should be avoided? uh, Patients with severe bleeding or obstruction should not be considered for a staging laparoscopy, because we have to anyway go for a laparotomy for a palliative surgery. So staging laparoscopy should be avoided in these patients. And another one is early stage diseases, that is T1, T2 diseases. Uh, it is not indicated, but in recent NCCN guidelines, although it is a category 2B recommendation, they are recommending to do staging laparoscopy from stage T1B, but it is usually recommended in the literature that in early stages uh, can be early stage diseases can be avoided from doing staging laparoscopy, and if there are severe upper abdominal adhesions from previous surgeries, staging laparoscopy can be avoided. This is one treatment algorithm for patients with the stage 3 disease, and uh, should be considered for a staging laparoscopy. If positive, go for chemotherapy, and but if, the recent recommendation is for going for a neoadjuvant chemotherapy if it is negative, and followed by surgery. Coming to the pods, the practical aspects of doing a staging laparoscopy. The first pod we put is a 10 pod at the umbilical region. After creating pneumoperitoneum, 30 degree 30-degree laparoscopy is introduced, and after visualizing all the peritoneal surfaces for any obvious metastasis and ascites, and we can insert another 5 mm trocar in the right upper quadrant, and another trocar can be inserted into the left flank also. That can be 5 mm or 12 mm trocar if we are considering an intra ultrasound. uh, if we are not considering an intra ultrasound, we can go for another 5 mm trocar, for considering entering into the lesser sac to look for any obvious infiltration towards the gastric bed, or any involvement of the serosal surface. Uh, these are the sides of pods. Uh, Usually, putting first one is the umbilical port, and two pods on the either sides. This is the NCCN recommendation. It's a category 2B recommendation that we should consider a staging laparoscopy and peritoneal cytology from a stage T1B, and uh, although the yield of peritoneal cytology in such an early cancer is less, some recent evidences are there showing that positive staging laparoscopy in this study, we can see they have a positive cytology in 18% of the cases. Um, but in this study, all these cases were poorly differentiated. All these positive early stage diseases were poorly differentiated tumors. So it is difficult to uh, going for a conclusion, and also there may be some error in primary staging also. This is another systematic review for the accuracy and indications for diagnostic laparoscopy prior to a curative intersection, and they included 21 articles from 1998 to 2009. Uh, went for a reverse staging. We will usually go from M stage to N stage, then to the T stage. M staging accuracy, sensitivity, and specificity ranges from 85 to 98 percentage, and 64 percentage to 94 percentage, and 80 to 100 percentage respectively. And the use of diagnostic laparoscopy altered treatment in 8.5 to 60 percentage of the cases, avoiding laparotomy in around 8.5 to 40 percentage. And the question that we usually ask is how many percentage of the patients can have a change in treatment, change in decision treatment. The usual most common reported number is around 25 to 30 percentage of the patients can have a change in their uh, decision regarding the further treatment. And laparoscopic ultrasound provided an additional benefit in 5.8 to 7.2 percentage. But laparoscopic ultrasound, the recommendation for the use of laparoscopic ultrasound is not standard. Their use is not recommended by, not routinely recommended by any of the societies. Next one is the extended diagnostic laparoscopy that we usually do in our institution also. That is the peritoneal and lesser sac exploration by adding additional ports in both the flanks, on both the sides of the primary camera site, and it can be complemented by laparoscopic ultrasound for better appreciation of pancreas, liver, and gastric wall thickness. And in our institution, we do laparoscopic ultrasound, staging laparoscopy, not for every cases. We do not we are not routinely doing for all patients with gastric cancers. We are recently we are doing mainly for thesis purpose, and we are doing mainly in gastric and OG junction tumors. And mainly we put three ports. First one is the camera port 10 to 12 mm, and left port we put a 5 mm port to elevate the liver, and also looking for any metastatic diseases in the mesentery and small bowel. And we can, and a right port and we will add for entering into the lesser sac to look for any direct infiltration by the tumor into the gastric bed or into the pancreas. And um, second look laparoscopy we do usually if there is any imaging suspicious findings in imaging after NSCT. And this is the result. This is actually the uh, result obtained from thesis of Dr. Vijay, and the total number of cases is 38, and positive peritoneal cytology is obtained from 15 cases. That is around 25 percentage. And deposits and cytology deposits. Cytology was actually negative for even for patients with peritoneal deposits. So 15 patients were identified with peritoneal deposits among 38 cases. Coming to the overall treatment algorithm, when a patient is having a localized gastric cancer, we will first investigate with endoscopy, and if there is any obstruction or bleeding, we will directly go for surgery. And if it is a T3 or T4 tumor, we will go for a diagnostic laparoscopy. And if it is a negative, then we will go for a curative treatment, that is neoadjuvant treatment followed by surgery. If it is an early tumor, that is T1 or T2, then we will not usually consider for a laparoscopy. These are the conclusions that we arrived. These are actually the answers to the questions I initially mentioned, which all are the indications that I already mentioned. Borman type 3, type 4 tumors, T3, T4 tumors, and also can be considered for patients with equivocal findings in CT scan, that is any multiple nodes, enlarged nodes in para-aortic region, or suspicious enlarged nodes in para-aortic region or perigastric region, or any suspicious infiltrations in the posterior part of the stomach. These are the indications. And coming to the next question, that is how to do, which all regions to be explored, and how to do an staging laparoscopy that I have mentioned, and what is the yield of doing, what is the how much accurate is the staging laparoscopy, that we can from the literature we can see a difference in numbers from Japanese and Western countries. That is around 50 percentage yield from Japanese and around 7 to 40 percentage from the Western countries, and the 0 to 17 percentage false negative rates are seen. Then the yield of staging laparoscopy was higher in gastric cancers in most of the studies than esophagogastric junction tumors, and related complication rates are only 0.4 percentage. So it is a safe procedure, and a repeat staging laparoscopy is actually recommended for all patients uh, after neoadjuvant chemotherapy to look for any uh, uh, progression in the disease which are not detected in CT scan. And if the efficacy of neoadjuvant chemotherapy for patients with a P0CY1 disease is established, it is not yet established actually. So staging laparoscopy in these patients can actually provide an oncological benefit. Thank you.
Gino, by the way, do you know any trial which shown the results of curative treatment by laparoscopy?
Sir, can you repeat the question?
No, you did. Your topic was about staging laparoscopy. What I am
Yes.
asking about the diagnostic therapeutic gastrectomy, laparoscopic. So what's the status now?
Sir, you are asking about laparoscopic gastrectomy for
Gastrectomy, yeah.
laparoscopic
Evidence,
gastrectomy for
evidence. Okay. In your opinion, this diagnostic laparoscopy is sort of preferable in most patients. Are you right? Am I correct?
yes, sir. For all gastric cancer patients, NCCN guidelines recommends to do diagnostic laparoscopy for all patients, or even for early gastric cancer, sir.
Okay. So our experience also shows that nearly 15 out of 38. You said it is 25%. That is not 25%. It's more than that. 30 out of 38, 15 patients had some or other metastasis in the abdomen.
Sorry, sir, it was a mistake, sir. It's actually 37%. 15
Okay,
out of 30.
and then that makes it significant.
Yes, sir.
But one thing is how do you do laparoscopic? Is it okay, if you look at the Vijay's thesis also, what was the pattern of metastasis which is identified? Which how many of them were peritoneal and how many of them were from other sites, and in how many of the patients the metastasis was identified after opening the lesser sac?
80% of the cases were having peritoneal deposits, sir, and only when the rest of the patients were having liver and cytology was negative for even for patients with peritoneal deposit. And 80% of them are having peritoneal deposits, and only rest of the few cases are having liver and less.
So none of them had peritoneal, retroperitoneal, or even lesser sac metastasis, or the nodal metastasis, which turned out to be inoperable on diagnostic laparoscopy.
No, sir. The lesser sac was having, none of the patients were having deposits in the lesser sac. Lesser sac we opened mainly for looking for any local operability. Any
So what is your recommendation? Is it opening the lesser sac or not opening?
root, sir, local operability should be checked for all patients, especially if the lesion is towards the lesser curvature or towards the posterior wall of the stomach. It can infiltrate into the pancreas. So lesser sac should be open for all patients and look for local operability, local infiltrations.
Yeah, but if you want to open a lesser sac, I think the other than two working ports, one more port becomes mandatory. Otherwise, you can't go in.
Yes.
So your three-port philosophy won't work here. The three ports will perhaps be useful for just putting a scope and two instruments and going to all quadrants, superficial quadrants. But if you want to really go under and see lift of stomach, I think you need to put one or two ports as well.
Excuse me,
Yes, sir.
Zero, can I ask a
Okay, sir.
question, Zero? Zero,
Sir.
Yes, yes,
what is
you're
the
audible. Let it. Go
indication?
ahead.
What is the indication for you're doing a laparoscopy for to assess for peritoneal disease, or are you looking for resectability?
Sir, our institution
Not
we are
our. What is
doing.
the official? What are the guidelines they're saying? Are we looking at resectability per se, or are we looking at peritoneal disease only?
Sir, peritoneal disease is the first one, sir. First major thing is the peritoneal disease. They recommend to go for a reverse TNM staging. That is, first one we will look for any metastasis. That is, M staging will be done first. Then any nodal enlargement will be looked for second. Then the T staging will be done last, sir. So actually, we are giving primary importance for the M staging, then going for the local staging.
Because if I come across even the Japanese trials, they're doing it for the staging purpose, not for the resectability. There are some trials who looked at resectability. They did a diagnostic lab, and after 1 week, they went in for the surgery, or the same sitting, they went ahead with the resective surgery.
Okay, sir.
So I should clear that. The different authors have different intentions of doing a diagnostic lab.
Okay.
No, basically, if you have a equivocal, very good CT scan, which suggests nothing of inoperability, I think a peritoneal metastasis alone should be looked for. But if you have Gino was mentioning in between, if you have a suspected posterior inoperability, I think it is better to go behind and open the SSI and see the nodal metastasis, because sometimes the frank infiltration. Again, whether to challenge this on dose of chemotherapy is another question which may come after. But you definitely know the chance of inoperability. If you do that, perhaps you can treat the patient aggressively or explain the patient or back out from treatment.
Yes, sir.
Yeah, one thing I want to tell. Anyway, it has significantly, there is actually a suggestion by the medical oncologist to look into start this diagnostic laparoscopic experiment, and it turned out to be good because a significant number of patients could be rescued from getting unnecessary chemotherapy and doing diagnosing a disease, advanced disease after chemotherapy, especially float and all very toxic. So whatever days or months remaining in the patient's life, if they subject for such an advanced treatment and declare futile after 3-4 months, then it's going to affect the patient's quality of life in a significant way. That's why the diagnostic laparoscopy is being popularized. But the issue is it is not done. Everybody agrees in all panel discussions that diagnostic laparoscopy has to be done upfront. But actually, this never happens because most of the patients cannot afford to have two procedures, especially if they comes under the various schemes under the government. And diagnostic laparoscopy is almost as expensive as the final curative treatment. So that holds back most of the centers from doing this repeat diagnostic laparoscopy at upfront.
Okay, sir. Okay, sir.
Okay, thank you.
Thank you, sir.
Okay, thanks for the second. Close the class, Navira.